We move into a study of traumatic spinal injury. You know that the spinal structures, an important feature of the spine, is through the foramen, the vertebral foramen, that the spinal cord, which is the final common pathway between peripheral nervous system and central nervous system, it is part of the central nervous system. It gives rise to both left and right spinal nerve roots. And if one of those nerve roots gets hurt, that's a peripheral injury. It's focal. If the spinal cord becomes damaged, then in a radical way, if it becomes severed, then there's no afferent or efferent communication from the periphery or from distal localities to the brain. So there's no motor signaling or no sensory signaling. I know you're very aware of that. This is a representation of a burst fracture, and this has traumatized the spinal cord. I'm going to talk to you about the grades of these injuries here in just a second. And here's represented for you an MRI of a similar kind of an injury. So we're headed into spinal cord injury. The location of the cord lesion determines the deficits. The lower down the deficit occurs, the less of the body will be influenced by that. If the injury is high, C4 or higher to C1, then there's tremendous loss of autonomic, motor, and sensory. If the injury occurred from in the thorax or in the lumbar or sacral regions, then that which is below the trauma will have deficits, motor, sensory, and perhaps autonomic difficulty. Primary injury has to do with right at the instant that the spinal cord was damaged, that deficit is what it is. When there's the metabolic processes that occur or deficits of oxygen to the injury site, then this can result in secondary injury that exacerbates what was primarily in place. And so immediate treatment is really vital. It may very well be that you're going into allied health or into the medical profession. You could specialize in these injuries. There's centers where their exclusive treatment is with people with spinal cord injuries. Now, I think retrospectively, you could say the same thing about traumatic brain injury. If you're called to this, you can spend a career researching and treating these kinds of injuries because of the prevalence of these and the magnitude of deficit that occurs. Spinal postures and loading have a lot to do with the type of injury to the cord and to the severity and the prognosis or the rehabilitation. Flexion and axial loading are the most problematic. Obviously, hyperrotation with either of the above can exacerbate it. And on your PowerPoint presentation, there's a video of a person who's sustaining a flexion injury that resulted in tetraplegia. I think you know it as quadriplegia, but also know that a synonym is tetraplegia. And then classifications of injuries to the spine. Primary lesions, there's very little hemorrhage that occurs. This results in transient signs and symptoms. This is like a bruising of the spinal cord. An intermediate, an impingement type of injury results in hemorrhage, and there's a chance to come back from this kind of injury, but there can be permanent injury to neurons, and the result of that could be long-term. And then when the cord is lacerated due to dislocation or burst fracture, at this point in technology, the person won't move again. unless there are robotics involved, where they have an exoskeleton where mechanically their limbs are moved. This is really moving forward. This might be, if you love machines and you love to create and you love to solve problems for people who without you would never move again. Oh, the body needs to move. And if the body can't do it by volition, if it can be done mechanically, the benefits to the person of getting up and moving, the lungs, the kidneys, the urinary system in general, certainly the pheromones that make you feel good about moving, all of those things are positively influenced by getting up and moving. And so there's a lot going on. And yet, we still are not able to, we've not realized yet regeneration of cord tissues once they're severed. Much research going on in that. When there's sensory deficit, this has to do with the afferent fibers that move to the dorsal horn of the spinal cord, the ascending tracts, and these reside mostly in mixed nerves. The manifestation is if the person has a complete loss of sensation, it's called anesthesia. If it's perverted, this would be tingling. This would be paresthesia. If it's a burning sensation, this happens very often when nerve tissue is stretched, elongated, or deeply compressed. That can result in a burning sensation. Those of you who've worked with collision sport athletes and they get into a position where their brachial plexus is attenuated or stretched, they talk about a hot knife that moves down their arm, and that's hyperesthesia. That's a burning sensation. And then dysesthesia would be where there's perversions of sensation. This schema is good for you to know. Sensory in and motor out of the spinal cord. And you can always identify the sensory nerve because the basal root ganglion is outside, or the nerve cell bodies are outside the spinal cord, not true in the motor nerves. And so just know that schema. Motor deficits can be manifested by the person doesn't have volitional control of a movement that they did before the spinal cord injury. They might have altered reflexes, absent reflexes, or hyporeflexes. And you know that reflexes, a normal reflex is graded as a 2, a hyporeflex is graded as a 1, and an absent reflex is graded as a 0. Now, it's possible to have hyperreflex as a result of disease processes, or, I guess now that I'm thinking about it, that can result as changes in metabolism in a person who's had spinal cord injury. So hyperreflex, in other words, you do the patellar tendon tap, and their leg shoots out, just way overkill, way dramatic, and that indicates an upper motor neuron lesion. Could be from infection or a neurologic disease, muscular dystrophy, or multiple sclerosis. And then autonomic insufficiencies. The person doesn't control automatic behaviors when they urinate, their level of arousal, the secretion of hormonal activity, which we count on as being automatic, that can be lost. And in cases where nerve innervation is missing, it may be that they're not able to control their bowel and bladder. And then respiratory complications, and I need to just pause here. And okay, I'm going to let that go. It may very well be that the phrenic nerve is depressed, and I'm not sure I have that right. So the nerve loss above C4 means that they lose mechanical control of their breathing. So C4, severing of C4, C5, I'll say it again, C3, C4 for sure, they'll lose the capacity to breathe on their own and will have to be breathed for. Okay? And brainstem lesions result in respiratory muscle dysfunction. So the respiratory center is in the brainstem, so if the brain swells right at the foramen magnum, there'll be stenosis, and the person won't be able to breathe on their own. Secondary lesions to the cord as a result of decreased oxygen or enzymes or the immune system attacking can result in ischemia and necrosis, and can result in secondary injury that leads to fatty deposits and further encroachments on the spinal cord. Okay? One of these formations is called a post-traumatic syringomyelia, and this is a tumor that puts pressure on the spinal cord, and that would have to be relieved with surgical intervention. Following injury to the spinal cord, one of the threats is dysreflexia, and this is where there can be an infarction in the retina or the kidneys, and there's a threat to cerebral vascular accident, which is a stroke, and this is because the blood pressure increases so greatly. You'll know that this is occurring because the person gets erythemic in their head. They get really bright red. They begin to sweat and have chills without a fever and a severe. This is the medical emergency. And so it is dysreflexia. That person has got to get to the hospital and get their blood pressure reduced. Okay. I was really blessed to read this in our reading in Goodman, and this is on page 1513. Rehabilitation to enhance the function and lifestyle of spinal cord injured clients has traditionally been aimed at helping clients achieve the ability to perform most daily tasks. The goal is to reach the point where the disability is no longer the major focus of the client's life. It is live. Life has changed, but live. And I think at the level of the spirit, the body, the mind, given the changes that have happened, come to grips with reality and make a choice that you're going to live. And you being able to communicate that with your patients in whatever pathology that they're dealing with is just a high calling and a real blessing to them. And the achievement is when they make that choice. They may not be receptive when you first say, hard news. But you stick with them, you stay cheerful, you pray to God for discretion about when to say things and how to say them. Sometimes people need to be told pointed things in a pointed way. Sometimes people need time to deal with their grief. That's going to be true when you're married or you have kids or you're working with friends who've had big loss, and certainly your clients who have spinal cord injury. It's a big loss. It's a big life changer. So be a student. You're getting ready to be a clinical professional, and being right ready to manage in the immediate and in the rehabilitation is way important. Okay, bless you. Bye.